Thanks so much for joining us today, Reid.
Thank you for having me.
Well, I'm really excited to have this conversation because, as I'd spoken to you earlier about, I've had clinicians here in Austin ask about eating disorders and psychedelics, and I know that this is a common condition that needs some more efficacious treatment. So I'm really excited that there's investigation in this area and that we get to talk about it today. So I would love to start our discussion by hearing a little bit about your background and how you got into studying eating disorders.
Sure, would be happy to, and thanks for having me. I agree. It's such an important topic because if you look at eating disorders, they're pretty underfunded, and there are no FDA approved medicine treatment options for anorexia, for example, just one for bulimia, one for uh, binge eating disorder. So there's definitely a need for new treatments, and these are difficult to treat conditions. And so, how I got into eating disorders, I didn't start my career focused on them. I'm a psychiatrist, but did fellowship training in genetics and clinical trials initially. Started my career in academics, had a lab doing gene finding expeditions, looking for the genetic causes of neuropsychiatric illness, and then studying new medicines, trying to, especially for treatment resistant conditions. That's how I came to work with ketamine starting around 2011. Did my first study of it then. And but my first real hands-on experience with eating disorders was quite early in my career. Um, of course, we get some in training, but I did a lot of psychiatric consult work and some inpatient psychiatric work, and really was drawn to this condition where all the eating disorders, in fact, because I've always had this view that everyone, we all have work to do in our relationship with food and body. And so that interest just deepened through the course of some experiences with my clients, um, and just working, doing my own work in terms of meditation and body-based practices, and then working with psychedelics more and more in recent years. I saw an opportunity there to hopefully bring new options to these conditions that so desperately need them. Um, and so I guess a few years back, I took a role full time as medical director of an eating disorder treatment center out here called Center for Change, and that's when I did my first psychedelic study for eating disorders specifically. Did a group based ketamine assisted psychotherapy study in 2018. The results, the feedback, anecdotally, and the results were quite positive. We're still writing it up for publication now, but giving the individuals a timeout from their eating disorder, and a chance to see things from a new perspective, and renewed hope on their recovery path was just so motivating for me.
Wow. Can you tell us a little bit about what that trial looked like? Was this intravenous ketamine?
It wasn't. I prefer to give ketamine intramuscularly. And so it was an IM ketamine study, although occasionally we would substitute in a nasal spray, for example, when it made sense. So I work with ketamine in all forms: IV, intramuscular, intranasal, sublingual. But this was the study design was groups of four individuals who were admitted to a residential treatment center for eating disorder care, who also had they had an eating disorder as their primary diagnosis, but they also had uh, severe depression and or PTSD. I think one participant had OCD as well, which does tend to co-occur most often with anorexia in terms of the eating disorders. So, and then we did that once a week for 4 weeks, the ketamine journey as a group. And then there was a lot of therapy in between, probably 3 therapy sessions in between, dietary sessions. And then we do our pre and post therapy work as a group. for that experience. It was really neat.
That sounds neat. I love the focus on intramuscular ketamine. I've done both IV and IM, and I found intramuscular to be, it's just a different experience. You're not hooked up to things, you're a little bit freer. And I don't know if it like let me relax, I think, a little bit more into the experience. So I'm glad to see that there are studies going on with that. When you said there are 4 in a room, and I think a lot of people have this question with the psychedelic assisted psychotherapies, is how involved is the therapist in the therapy? Especially when you have 4 people around, are you just there if they need it, or are they actively seeking out you to speak with at times?
Yeah, so it's a really good question, a fun one. And there's a little bit of both. I'd say with IM ketamine, especially as we escalate the doses through the course of, say, 4 total journeys that we did in this study, you become less conversational, but not everyone. That was in general. That there were benefits to the group experience, but I've got to say there were also the occasional days that were distracting to others if someone was particularly vocal as a group. So it was 4 individuals with me holding space and 1 or 2 nurses, sometimes another practitioner. But sometimes I would invite their primary therapist, who was working with them the most in this setting in the residential center, to come in and help talk them through it. So it's kind of like an MDMA therapy session where you're in and you're out. If someone's having a difficult time, we would go over to them and sit with them and check in. But it was a headphones and eye shade experience by default. But there was a fair amount of interaction. I also work with ketamine in those other forms at psycholytic doses, pre-therapy, or sometimes we'll even do an IV and do some guided work that way. But for the most part, I'd say intramuscular ketamine is more of a transformational personal journey, but we really like to tie the therapy pre and post to it, and then do the integration work in between sessions.
And is there a specific type of therapy that you found worked well in conjunction with the ketamine? Like, we know there's different types of therapy. There's CBT or EMDR. What did you use in this study, and what did you all find effective?
Yeah, and this study in particular did not get specific about which kind of therapy. I think that's another great question, because ketamine and other psychedelic medicines are therapy aids, therapy boosters, accelerators, or catalysts to the therapeutic process. And I think there are some that lend themselves a little better than others to a psychedelic type experience, but a bigger factor, in my opinion, is the therapy that the therapist is most comfortable with, most well versed in, and how they show up with that therapeutic modality to the experience. And so in this one, it was eating disorder focused therapeutic modalities for the integration. But I did just do a study that we recently completed here in clinic, and did it in collaboration with a colleague and friend, Adele LaFrance, who developed emotion-focused family therapy. We co-created a therapy modality to go along with ketamine called emotion-focused ketamine-assisted psychotherapy, and just did a clinical trial, an open-label feasibility study of anorexia nervosa, and that's based on EFT principles, emotion-focused therapy principles, that I think also lends itself well to ketamine. But to answer your initial question, some of the other ones, there's internal family systems goes well, parts work in general. We use EMDR here in clinic with ketamine, even in the psycholytic dosing sometimes, Hakomi, transpersonal approaches in general, and even CBT, DBT, ACT. I really think more work is needed in this area, but there aren't therapy models that we commonly use that really don't go well with ketamine sessions, especially in between, if this is integration psychotherapy.
Well, that's good to hear. I want to clarify a term that you're using, and we just had Dr. Mark Brownstein on, and he used it too. Psycholytic. Can you talk a little bit about what a psycholytic dose is?
Yeah, and so if you look at Phil Wolfson's ketamine-assisted psychotherapy papers, he calls the two ways of giving ketamine transformation and trance dosing. Uh, I like calling the trance dosing psycholytic, and it just fits better for me, and it involves giving a lower dose to facilitate openness and to uh, dissolve some of those barriers and obstacles to fully participating in the therapeutic process, including uh, the walls that we have oftentimes put up by necessity when traumatic things happen. And a psycholytic dose can assist the individual in moving towards those negative affective states or really difficult memories that might be walled off. Um, and also just open up the individual in general to doing the therapy work.
And so when people have
So
seen these, especially in COVID era, when these options have popped up, you might see ketamine assisted remote therapy. It's most likely that they're doing a nasal or a lozenge form of ketamine at a psycholytic dose with the therapist there over Zoom, correct?
yeah, I don't do that myself, and I've had the same question. We've even, with colleagues, done some digging and looked up people's experiences that they shared on Reddit going to such and such a clinic. And to be honest, it seems like both ways are happening, where an individual might go home with even a high dose lozenge, take it, not be talking through the experience, but then debrief on Zoom with the therapist. I personally don't send someone home with ketamine unless they've had a ketamine journey, well, ideally several, with me in clinic, and a support person who I know and have provided some skills training to help hold space. Um, but I'm all for creative approaches to navigating this pandemic to still give help to and hopefully expand access to those in need for sure.
Yeah, I appreciate that input. Things to think about when looking at these different options. Now, getting back to the initial trial you were talking about, you said you both had anecdotal evidence of success and actual like the study parameters. Can you tell me a little bit about some of the anecdotal findings you had?
Yeah, yeah. So I remember a couple stories come to mind. There was one gal with anorexia who had been battling this condition for a number of years, and um, really knew really felt disconnected from her body and from food in general, really did not enjoy it, and had some deep, I don't know, soulful hunger that was just unfulfilled by food, but uh, and just ended up in these patterns of restrictive eating. But when she got ketamine the very first time and every time thereafter, she became embodied and free, like creatively free. She kind of felt like her truer self. And the embodiment, the reconnecting with oneself, uh, lasted for days, not permanent. That's one thing about ketamine for depression as well, is the benefits are often temporary. It might be a week or two or three, and that might be enough to pull someone out of an episode. This temporary kind of significant embodiment and reconnection with tastes and hunger cues and fullness cues, uh, even though it was temporary, it was extremely helpful for this individual to see what's possible and have some renewed vigor on her recovery journey and doing the work. So that's one kind of anecdotal experience that came to mind. Another was about healing from trauma. It wasn't IM injection, but it was an individual who was, some people are vocal during, even if it's just talking, and we're helping to capture those to go over with the individual in therapy after. So this was a gal with anorexia and OCD, and likely PTSD, although she had never been able to approach that in therapy. And so she went back to not only one, but two different traumas and talked about them to me and the nurse I was working with for the first time ever, was able to share, and it opened a door to processing that and releasing that, feeling it to heal it. So it was a difficult one for her in the moment, but extremely liberating in the weeks and months that followed.
I can imagine. Thank you for sharing those stories. Can you talk a little bit about what the objective findings showed from that study?
Sure. We measured, because these were more routinely gathered at the center, the PHQ-9 for depression and the GAD-7 for anxiety, along with the eating disorder outcomes and dietary progress parameters, vital signs, and daily weights, and all the things we were already collecting. And our primary outcome, or our hypothesis of the study, was that we would see reductions in depression and anxiety scores and improvement in overall eating disorder progress. And we did. We saw significant reductions even in a small study. I think we gave maybe 50 doses across 12, 13 individuals through the course of the study, but we still saw significant reductions in depression and anxiety that persisted through the course of the study, even though we did see a pattern of some initial benefits. And then as the next dosing session came up a week later, there was some return of depression and anxiety symptoms starting to show up.
And so how many doses, you said they got 4 total, correct?
Yeah.
Did you notice that the period of time it took for those symptoms to return would get longer as they had more doses, or was it pretty consistent?
Yeah, in general, there was, and I see that in clinic as well, in a clinical course of treatment. Some people don't respond to the first session. Most do get some benefit, but then for most individuals, that's not a permanent one and done kind of thing. But I do believe that there are lasting benefits, especially when you pair it with the psychotherapy, when you have this window of opportunity of neuroplasticity to do some deeper work and lay down some lasting benefits. And that's kind of my impression of what was going on in this study is, we'd have some temporary significant relief from mood and anxiety struggles, letting the individual go deeper in their work and resulting in some lasting changes. Although this study did not include long-term follow-up. So we know what it looked like at the end of the month course. And I have some anecdotal feedback from a year later, but we don't have depression scores out to really quantify that. Which is why we're doing more studies now.
Was there, you talk about the scales for anxiety and depression. Is there a correlate for eating disorders that you could tell, like, okay, where they are in their eating disorder journey is improved after these 4 sessions?
So there are, first of all, eating disorder diagnoses co-occur often with depression, anxiety. In fact, more than 50% of individuals with an eating disorder who present to a treatment center will have depression and or anxiety. And they do tend to track relatively well together. But in that kind of 24-hour care setting, we also have a lot of other data, eating disorder wise, including how someone is able to do with their weight restoration. If they're underweight and therefore to get some nutritional rehabilitation, for example, and how they do with their ability to stick to their meal plan they come up with the dietitian, and how much they're able to forge ahead in that regard and advance through the levels of progress. Like, we'll start someone when they come into a treatment center where they get plated a meal plan, and then they'll do some more self-plating, and then they'll do some challenges, and then they'll progress, some will anyway, to an intuitive eating approach. So that's my goal in working with individuals, and even though sometimes it does take time, is getting to that intuitive path forward in both food and body and in life in general.
And were you finding that the group that had done the ketamine sessions were able to progress a little bit more quickly toward that than their counterparts?
And that's what I don't have enough long-term data to say. I do see some trends towards quicker weight restoration. There was one person who, in fact, the first person I was talking about, who had that significant reconnection with self, like coming home to oneself in a very drastic way. They even asked, after I think maybe the second ketamine session, if they could temporarily have a feeding tube, because they for the first time felt the impact of the meal plan they were on. They felt what food was like in their body. They felt fullness like they had never before, because there was a disconnection there previously. And that was temporary. That's a few days. So it sounds like backwards progress to some, but to me it was quite positive, especially that they were asking for that and we collaborated on it together. But healing can be disruptive sometimes, and you do feel worse before you feel better in some cases, like with PTSD, for example. Sometimes that happens.
Yeah, and I'm glad you brought up PTSD, because I wanted to ask about the correlation between trauma and eating disorders, because we know that psychedelics are helpful in addressing trauma, and I'm assuming that we're finding there are trauma incidents at the core of a lot of conditions. Is there a corollary with or a connection between the two with eating disorders and trauma?
Yeah, there is a high percentage of trauma, both childhood and later in life, in individuals with eating disorders, especially serious ones. And if you look at the different eating disorder categories, say the main ones, bulimia and binge eating disorder tend to have a higher percentage of co-occurring trauma than anorexia does. Eating disorders are always a perfect storm of biopsychosocial issues. You're born with a genetic kind of deck of cards. And in anorexia, that might involve some really good traits that in this perfect storm can run amok, like perfectionism and drive and things like that. So that's more often the mechanism, and also that over control phenotype is why OCD tends to run more commonly with anorexia than, say, bulimia. And this isn't an absolute, of course. This is general trends, but bulimia and binge eating disorder do tend to have higher rates of trauma, and it is a significant issue. It's sad even to think about how much trauma there is out there. Although that's why we're here having this discussion. There's hope and there is healing on the flip side.
Yeah, I appreciate you sharing that message of hope, especially in these times. We love to hear it. Before we go on to other substances, have there been further studies done with ketamine and eating disorders?
So the first published ketamine and eating disorder study was quite a while ago, a couple decades ago, and it was an interesting protocol where it was an IV drip over many hours, and it showed some reductions in compulsive eating scores. And then there have been case reports about ketamine and eating disorders, but um, not many, no big scale controlled trials. Um, there's this group-based one that we're writing up, and the anorexia FCAP one we just completed and are also um, now looking at the results for. Um, but I do think that multi-site studies, bigger studies are needed, and that's one of my hopes for next year in the path forward. Not just this MAPS study with MDMA and eating disorders that we may chat about, but doing some bigger studies with ketamine and Spravato.
Nice. Well, since you brought it up, can you tell us about these planned studies with MAPS for MDMA and eating disorders?
Yeah, I'd love to. So, eating disorders, two of them in particular, are the latest internal indication that MAPS is running studies around anorexia and binge eating disorder. Um, Bulimia, I'm hoping and assuming, and is coming next, but because there are some electrolyte imbalances at times and specific cardiac concerns, um, that's placed just kind of naturally strategically next in line. But the initial study that I'm helping with is MDMA assisted psychotherapy with caregiver involvement for anorexia and for binge eating disorder. Are there are a few sites. Adele LaFrance, who I mentioned, is the strategic lead, the PI of that, and I'm the coordinating investigator for that study, where I'll train the sites and the study teams in how to do the research and the eating disorder treatment tied to it, along with some MDMA science, which is fun as well.
Nice. Will that look like the MDMA sessions that we're familiar with from the PTSD trials?
Yeah, it will be. It's a similar protocol. Otherwise, there's caregiver involvement, but the caregivers in this particular study don't receive the medicine, and they're not, by default, they're routinely present for the dosing sessions, but they're there for some preparation and integration, and they're doing also alongside some. They're receiving some support and skills to help them help their loved one through the integration process.
Oh, that's a really
Because
nice
yeah, that's
adjunct.
yeah, it is. There's only so much we can do in clinic and in the therapy room in an hour of therapy, but if you can leverage both the neurobiologic bonds between loved ones, whether it's a spouse, a child, or a parent, uh, and provide some more skills and support, then I think we maximize our chances of good outcomes and full recovery.
Yeah, absolutely. Will the setup also seem a little bit like the PTSD ones where there were a few sessions beforehand that are psychotherapy only, then you have a number of sessions with the medicine and then a few sessions afterward?
Yeah. It's the same kind of study design. In the PTSD studies, you'd often see two or three dosing sessions. In this one, it's three dosing sessions, roughly, a month apart. And so it's a few month study with a lot of prep and integration in between. And the dosing is the same as well, essentially, as well as the duration of the sessions. It's otherwise using the same approach that MAPS has been doing such amazing work with, and bringing MDMA forward along this path for PTSD.
Nice. Is that one already fully enrolled, or are you still looking for subjects?
It actually hasn't started enrolling. We got through the FDA IND process. There are two sites in Canada, so through the Health Canada process as well. And IRB approval went well. Now we're just gearing up to start the study, start enrollment in the new year.
Okay. All right. Anybody listening who's interested, have a look out for that, maps.org. I'm sure we'll list that. And then let's talk a little bit about, I know you have psilocybin for eating disorder work planned in the future, some investigations on that front. Can you tell us a little bit about that?
Yeah, so that one is more in the ideation phase, the protocol development phase. But my plan is to do a clinical trial using psilocybin and, of course, psychedelic assisted psychotherapy along with it for bulimia that unfortunately hasn't gotten as much attention specifically in these studies because of some of those things we were talking about, like some medical considerations. But I do think psilocybin especially is well suited, and a safe plant-based psychedelic medicine that we could use for this population. So that's months out though, and still working on the logistics.
I understand. I'd love to wrap up by asking you a little bit about what you think the mechanism may be behind why these different medicines work. You can either discuss them as a whole or, ketamine and MDMA separately, but I'd, love to see if you have some hypothesis on why these are effective for eating disorders.
Yeah, I'd say psychedelics in general, psychedelic meaning to wander in the mind, they give us a new perspective, let us see the forest from the trees, and a few different specific mechanisms. Like with ketamine, it's an MDMA receptor blockade. There's the rapid antidepressant response, kind of like you're waking up a dormant part of the brain, like you're jump starting a car. And with other psychedelics, classic psychedelics, there are also significant improvements in mood that come in a similar way. But what they have in common, the classic psychedelics and some of these others, like psilocybin, for example, are this window of neuroplasticity, provide an opportunity for deep therapeutic work. Sometimes I'll think about these, it's kind of a silly analogy, but as miracle grow for neurons, and then along those same lines, ketamine in particular, there was a paper a couple of years ago showing it turns off this burst mode in a little part of the brain called the habenula, the lateral habenula, that's in hyperdrive in depression and stressed out states. And ketamine provides very rapid relief, although temporary relief from that. And then many of these also, well, we could chat about the default mode network. I think is a huge factor in how these tools may work in eating disorders in particular. Because if we look at the default mode network as the neurobiological seat of the ego, that collection of pathways that govern our self-image, our stories, our autobiographical memories, our deeply ingrained patterns, then this in eating disorders, this shows up, overactive default mode networks show up as like ruminating over caloric intake and food rules, compulsive eating or exercise patterns, body checking, comparison. And so it's kind of like that ski slope analogy where there are these ruts or grooves or indentations that we've made from repetitive patterns, and psychedelics can come like a fresh coat of snow, provide a blank slate to more consciously choose the path forward. But if we're not pairing them with therapeutic work and all the supports we can, then there's a risk, of course, of things snapping back into place. But I do think that downregulation of the default mode is such a powerful and welcome break from the day-to-day patterns in these conditions.
That makes total sense. Well, I truly appreciate all the work you're doing in this field. I'm sure this will help so many people out there. Is there a way that people can find out more about you and the work you're doing?
Sure. I'm My home base is at novamind.ca. I'm the chief medical officer there, and that links out to our clinics and research clinics. But you can find me at novamind.ca.
Excellent. Well, Dr. Robison, Reid, thank you so much for joining us today. I really appreciate it.
Ray, it's been so fun to chat with you.
All right. Well, until next time, for everyone else out there.